Well, hello and welcome to my Sunday morning coffee talks with Dr. Childress. Today, I want to be discussing treatment plans, mental health treatment plans in the family courts. And with that, the important thing to understand that whatever the problem is, we need to fix it. And forensic psychology took us in a bad direction where we got fighting about custody. This isn't a custody issue, it's a treatment issue. And whatever the pathology is, I don't care what it is, autism, ADHD, child abuse by mom, child abuse by dad, it doesn't matter what the pathology is. Whatever it is, we need to fix it. It's always in the child's best interest to fix the problems in the family. So, custody is actually a false issue. This is a pathology, and we need a treatment plan to fix the pathology. And what the pathology is doing, the pathological parent, is they're driving this into the wrong system. Okay, so they're driving this into the legal system to fix a pathology. No, no, no. This needs to go into the healthcare system. That's the system that fixes the legal system. Judges don't diagnose pathology. Judges don't come up with treatment plans. So whatever the problem is, we need to get it over to the healthcare system to get a diagnosis, an accurate diagnosis of the problem, so we can come up with an effective treatment plan. So I would recommend to the family courts and all the judges and the legal people that the moment you encounter a highly litigated custody dispute involving attachment pathology with the child, the moment you encounter that, pop it out to get an appropriate clinical diagnostic assessment of child abuse to the differential diagnosis for each parent. And then let's get a treatment plan that effectively fixes whatever it is so that we get the child a normal range and healthy childhood. That's what we have to do. So, this whole custody thing, though, is a false issue. And we need to return to the child a normal range and healthy childhood. That's our obligation. We need to fix the problem. The idea that this stuff is going on for years is just simply unacceptable. Now, in terms of understanding a treatment plan, this is so incredibly basic to mental health, to all doctors, that the idea that I'm explaining to parents what a treatment plan is just phenomenally bad professional practice among the doctors, because we should already know, and we should be doing this, and we should be giving you treatment plans just sort of matter of course. And the reason I put up WikiHow here, and there's a link, you Google WikiHow mental health treatment plans and it'll show up. And the reason I do that is because it is so common, so standard of practice that WikiHow explains it. And so if the mental health professional is not practicing at the level of WikiHow, that's just, they're not even at the level of a professional in any capacity. So we need to get standards back in the family courts. And the question becomes, how did they ever become so bad? And I would look directly at the licensing boards. They're the ones who are supposed to enforce ethical standards of practice and competence and protect the consumer. And they are absolutely failing if I'm having to explain treatment plans to parents so they can request one, but they're not going to get one. You're not going to be able to get a treatment plan out of the surrounding mental health people. They'll look at you with like deer in the headlight kind of stuff. But here's from WikiHow. Here's from what they say, and you can look at it. So they say record the treatment plan components in the one section, and they say the client's name and diagnosis. Notice, because diagnosis guides treatment, so they're supposed to put the diagnosis on the treatment plan. Long-term goals, such as I want to heal my depression, so I want to restore a healthy attachment bond with my child would be the long-term goal. Short-term goals or objectives. Now note this. Notice how the goals are specified in measurable ways. So client will reduce depression severity from 8 out of 10 to 5 out of 10 within 6 months. So notice there's a time frame on the goal accomplishment, and a good treatment plan will have at least 3 goals. And then, oh, notice this: dates and signatures of therapist and client. Now, if you're going to sign something, that means it's written, right? Because you're signing a document. And so it's assumed that you get a written treatment plan. It is assumed that you're going to sign the written treatment plan. So, for all parents out there, if you don't have a written treatment plan for your child from the family therapist or from the individual therapist too, if you haven't seen a treatment plan with a diagnosis and you haven't signed it, then we're at beneath professional standards of practice. We're beneath WikiHow at that point. So you need to get back up to WikiHow and get a written treatment plan with a diagnosis, and that everybody agrees to and is signed off on by everybody and the court. Once we get a written treatment plan, the court can look at it too, and everybody will know what's happening, and we can fix the problem. But it depends on an accurate diagnosis. That's the key. If we try treating cancer with insulin, the patient's going to die from the misdiagnosed cancer. So, let me explain for a second about mental health reports and what a mental health report should look like. This is a type of thing that if you ask for a treatment progress update, or if we get assessment, initial intake assessment report from the mental health person, this is the structure of what it should look like. So we have a reason for referral that'll describe your current symptoms and behavior. Then the histories, all the various histories, that's history of the problem, the family history, other histories, social, educational, work, medical, legal. So we describe whatever's going on that's impacting the issue. Then we do a summary, about 3 or 4 paragraphs of a summary of everything. Then we put our diagnosis, DSM-5 diagnosis. Notice WikiHow, when they talk about it, they'll say, do your DSM-5 diagnosis. And then based on the diagnosis is our recommendations. Okay, so if we skip the step of diagnosis, we can't make recommendations because we don't know what we're treating. The other feature about this is that all those history sections, as I'm describing family history, social history, medical, whatever the relevant history surrounding the problem, as I'm doing that, I'm noting the symptom features that are later going to result in my diagnosis. So that any mental health professional who's reading this professional level report will be able to tell what support there is for that diagnosis. How did you reach that diagnosis? So, for example, when I was heading up my clinic and I'd have postdocs or interns submit their intake reports to me, and the diagnosis they're going to land on ultimately is something like ADHD. Well, in the history section, I want to see the 6 symptoms of ADHD, 6 of 9, that are the criteria for the diagnosis. And so if they didn't list the 6 of 9 symptoms somewhere in that history section, then I'm going to kick it back to them and say, I'm not seeing where you're supported, your diagnosis is supported, and they're going to have to edit it up and indicate the symptoms, or put the diagnosis on a rule out or something if they don't have it. But we should see the symptoms in the report, and then the diagnosis should flow from the symptoms, and the recommendations flow from the diagnosis. And for the court, as a way to understand what should be coming out of the mental health professionals, when the court writes a verdict, they have a trial, and the judge writes the decision. The judge indicates the laws that were applied and how they were applied, and which ones the decision said yes and which one said no, and why. They provide their decision and the support and reasons for their decision. The exact same thing should be coming from the doctors. We should provide our diagnosis that's clear to everyone once we get a report from a mental health person, we shouldn't be arguing about the diagnosis. That should be done. And we should have a clear diagnosis, and it should be supported. You should be able to read the report and see why they came up with that diagnosis. And then we can challenge it as a misdiagnosis and offer up other things, but at least we should have clarity on that first piece of stuff. Now, here's what a forensic custody evaluation report looks like, because I review them all the time. This is a standard approach for a forensic custody evaluation. If you've had one, you can verify this is what they do. First, they audio record the interviews. And I can tell that because they use all these quotes. And there's no way you could remember all those quotes. So what they're basically doing is audio recording it, sending it out, getting a transcript of it, and then they're simply using the transcript as their history and symptom section. And that's just awful practice. That's adding no professional level activity. You just simply tape recording things and then preventing the transcript. You're just basically conduit. You might as well have all the parties just send their statements directly to the judge. We can save a lot of money. And so that's just way inadequate practice from these forensic psychologists. Then they do some random testing, often or sometimes the MMPI, sometimes not. And so it's very variable as to the qualities that they do on this. And sometimes other personality tests, and maybe add some other tests kind of measures for unclear purposes. Then they come up with their conclusions, which are entirely personal opinions. They apply no established knowledge to any of the information they report. That's what I do. I review them, second opinion. I apply the established knowledge, and they're zero. And so they're just personal opinions. Their recommendations, they don't provide a diagnosis. So the recommendations are also simply personal opinions, not based on diagnosis, not based on any established knowledge, just personal opinions. And I would offer up that a high school student could conduct a forensic custody evaluation. So let me put that on the table. I'm willing to debate with any forensic psychologist anywhere, anytime, set it up. Could a forensic custody evaluation be conducted by a high school student? I will say yes, and you can get them to say no, it requires some specialized expertise, but I'm just not seeing where or how. If we just farm out the testing to a psychologist, then the entire rest of the custody evaluation, other than an MMPI or some Rorschach or something, could be done by a high school student. Just let me point out Robert's apperception test for children. If you want to know what's going on with a child, conduct a Robert's apperception test with children. Is that conducted in any forensic custody? No. Why not? They're just lazy. And that speaks to the fact that even when they're doing their MMPIs and Rorschachs or whatever testing there, it's nonsense testing. This is the test you would want to use, but they don't even know it because they're lazy as sin. They are just lazy, ignorant, incompetent, and no one's holding them accountable. Who's holding the forensic psychologists accountable? With their big puffy vitas, and they're working in the APA, and they got head positions at the AFC. Who's holding them accountable for competence, for the work product they're producing, this experimental new approach? Nobody. Who should be? Licensing boards. APA. APA is the one, they kind of put their imprimatur on this. They've got like recommendations for forensic custody evaluations and stuff. They're supporting this. So the APA is in the bed absolutely 100% with the forensic psychologist, and they're covering up. The APA is currently covering up for the malpractice in forensic psychology, for the unethical malpractice. And I'll support that. Yeah. So here's the treatment plan structure. WikiHow kind of brought it up, but basically there's 4 parts to a treatment plan. There's the goals identified in measurable ways. So for this court-involved pathology, I would recommend we do an outcome measure, and we want a return to normal range affection, cooperation, social involvement. So that we have short-term and long-term goals, intervention specified for each goal, timeframes for goal accomplishment with interim benchmarks. If oftentimes we'll by 6 weeks this will happen, but the long-term goal will be 6 months or something. And then outcome measures. We always have outcome measures in clinical psychology. How do you know if your treatment's working if you don't measure those symptoms that you're targeting for a change? So the idea that we don't have outcome measures in the family courts is phenomenally bad. And I would recommend daily ratings on affection, cooperation, and social involvement. So let's talk about outcome measures for a second. This is what I recommend. And I developed it 3 items, and I call it the parent-child relationship rating scale. It's up on my website, but it's just 3 numbers on a 1 to 7 Likert scale. Easy peasy. Okay, it's not some big thing. It was just measuring or monitoring the symptoms of concern in the family to see if we fix them, because we need to fix them. We need to fix the problem. And so the symptoms I recommend that we monitor for this, these are the symptoms that will be impacted by psychological child abuse, is affection, cooperation, social involvement. And every day, the targeted parent rates the child on those 3 items, 1 to 7 scale. 1 to 2 is awful, 6 and 7 is wonderful, 3, 4, 5 is normal range, and sends those 3 numbers to the family therapist, who puts them in an Excel file. And then every week in family therapy, you talk about the ratings and were they accurate, and do you want to adjust them, or what's normal in the family, and you address the symptoms. And I would recommend the treatment for attachment pathology. With this, if it's authentic parent-child conflict between the targeted parent and the child, treatment should be about 3 to 6 months with a cooperative parent. It's really easy to fix attachment pathology with a cooperative parent. You just change their parenting and the child bonds right back in again, if it's actually a 2-person causality. If it's a 3-person triangle and is being caused by the pathology of the allied parent, then treatment's not going to work until we address the proper diagnosis, child psychological abuse by the allied parent. Which forensic psychology, let's talk about them for a second, because they are disabling the mental health system response in the family courts. They're clogging it up with their forensic custody evaluations. We need to get a clinical diagnostic risk assessment for the family. Instead, we're getting this bizarre, just awful forensic custody evaluation. We need to clear forensic psychology out of the family courts so that we can get clinical psychology and treatment back, and we can fix the problem. So forensic psychology is disabling the mental health system response in the family courts. So this is child abuse pathology in the family courts, and that's just a fact. That's just what we have here. We have child abuse pathology in the family courts. So either the targeted parent is abusing the child in some way, and we need to identify if that's true. Identify what the targeted parent is doing that's abusive. I have a parenting practices rating scale that we can actually identify specifically what's going on, so we can put it on a treatment plan and fix it. That's what we do. We fix stuff. So if the targeted parent's abusive, let's identify how, let's put it on a treatment plan and fix it. But is that parent creating the child's pathology? Or the other alternative is the allied parent psychologically abusing the child by creating a shared or induced persecutory delusion and false factitious attachment pathology for secondary gain to the pathological, narcissistic, borderline dark personality parent? So there's our 2 possibilities. One, the targeted parent is abusing the child, or the allied parent is psychologically abusing the child. But when we have significant pathology, attachment, a child rejecting a parent That's about as bad as attachment pathology gets. Okay, we have insecure attachment. The child's still trying to bond to the parent. Child's rejecting a parent. That's either child abuse by the targeted parent, which is implied by the child's symptoms, maybe even overtly by allegations, or if it's not that parent, it's the other parent, the allied parent, who's creating that level of child symptoms, which is child psychological abuse by that parent. So this is important to understand. Based on the differential diagnoses for the pathology, for the problem, all court custody cases should be returning a child abuse diagnosis one way or the other. If the targeted parent is not abusing the child, then the allied parent is. Now, I was asked this question in cross-examination the other day. It's like, if you rule out, if there's only two possibilities, either the targeted parent is abusing the child or the allied parent is psychologically abusing the child, and we rule out one of the alternatives, well, guess what? There's only one left. But I don't want to diagnose a pathology because I'm not like, that's not my job. I don't have duty of care obligations. It's their job they have the professional obligations to accurately diagnose the pathology. But if you only got two and you eliminate one, it's like, it's pretty obvious. And so I would argue that there's a misdiagnosis because forensic custody evaluations are not returning child abuse on any of the custody evaluations on any of these families. And when we expect it's going to be a diagnosis of child abuse one way or the other, and we are getting no child abuse diagnoses, they're misdiagnosing the pathology. So they rule out the targeted parent as being abusive, but they don't go the next step and diagnose the allied parent as psychological abuse. So I'm going to offer up that they're misdiagnosing the pathology. Routinely and consistently fail to diagnose the child abuse pathology in the family, which then misleads the court. It does not providing the court with the necessary information the court needs to make its decisions. So I will offer that the forensic psychologists cannot now acknowledge the child abuse within the family without also acknowledging their previous misdiagnosis. And that's critical to understand about how they are disabling the mental health system, because they will resist now identifying the child abuse because it means they didn't identify it before. And so they are in a motivated position to deny the pathology in the family and to not allow clinical diagnostic assessments because it will reveal that they failed in the duty to protect, reveal their malpractice, and oh my goodness, there could be all sorts of bad consequences, which there should be for the failed experiment. So, forensic psychology is a failed experiment in service delivery to a vulnerable population. Forensic psychologists are disabling the mental health system response to the pathology in the family courts for their own financial and career status gain. And here, New York Blue Ribbon Commission outside independent review said these members reached the conclusion that the practice of forensic custody evaluations is beyond reform, and that no amount of training for courts, forensic evaluators, or other court personnel will successfully fix the bias, inequity, and conflict of interest issues that exist within the system. And that's important to understand, the conflict of interest issues. Look what happens when we get an outside independent review of forensic custody evaluations. They get slammed, lack scientific and legal value, dangerous, harmful to children. But why isn't that known? Why do we have this continuing to go on, knowing that these forensic custody evaluations lack scientific and legal value, are dangerous to children, are potentially harmful to children and families. Why do we allow them? Because the forensic psychologists have the power and they are disabling the mental health system for their own financial and career status gain. And these people have names. You want to know who they are? Just look at the top echelons of forensic psychology, and they're the ones who are disabling the mental health system response. So if they don't want to do that, just let's get back to clinical diagnostic assessments. Boom. And within 4 to 6 weeks, we can get a diagnosis of child abuse back, but that will indicate that they were not doing that for their entire time. Now, let me talk about one other group of problematic mental health people in the family courts. These are the individual child therapists. I will offer to you that they are participating child abusers. All of them. All the individual therapists, I will say, are child abusers. And so let's explore that a little bit. So, I will offer that all individual child therapists have misdiagnosed the pathology because, one, they failed to conduct a proper assessment, so the negligence, and two, they are practiced beyond the boundaries of their competence with delusional thought disorders and factitious disorders in the family courts. And as a result, I will offer that they are participants in the child abuse. All of them, all individual therapists are colluding participants in the psychological abuse of the child by a pathological parent because they have negligently, they're just lazy, misdiagnosed the pathology in the family. And, they don't know that this could be a persecutory delusion. They don't know that this could be a factor. And so when their client, the individual client, just comes in and tells them that, oh, I'm being mistreated, they go, oh, you poor thing. They are validating a delusional belief. It's like somebody comes to you and says, my CIA is poisoning my food. And you go, oh, my goodness, let's go contact the police. It's a delusion. You never validate a delusion. That's not the treatment for a delusion. Oh my goodness, the CIA is poisoning your food. Let's contact your congressman. No, it's a delusion. We always challenge the delusion. I know you think that, but that's not actually true. But if you don't know that, if you've misdiagnosed the pathology like the individual therapist, they wind up going, oh, you poor thing, and validate the delusional belief. They become a participant in the child's psychological abuse because they are ignorant, incompetent, unethical. They fail to conduct a proper assessment because they fail to understand what the pathology they're working with is. And so they're child abusers. Well, that's from where I sit. That's what I'm looking at. We got a bunch of individual therapists who are child abusers. If you believe a shared delusion, you become part of the shared delusion. You become part of the pathology. And when that pathology is a psychological abuse of the child by a pathological parent, you become part of the psychological child abuse because of your negligent and incompetent misdiagnosis. So I will offer that all individual child therapists in the family courts are participating child abusers because of their negligently incompetent malpractice. I'm willing to debate this anytime. Get somebody involved. Let's find out if I'm right. Is the child therapist, individual child therapist, a child abuser? That's the allegation coming from Dr. Childress. So let's find out. What's the diagnosis guiding the child's individual therapy? Did the child's individual therapist conduct a proper risk assessment for the child, for their client, to the appropriate differential diagnoses involved? Is the individual child therapist competent, even competent, in the diagnostic assessment and treatment of delusional thought disorders and factitious disorder imposed on another? Because that's the pathology then that we're worried about in the family courts. So are they able to diagnose the pathology in the family courts if they're working with children in the family courts? I would say no. I would say they're not competent. They didn't conduct a proper assessment, so they're misdiagnosing the pathology. As a result, they're participating in the child abuse. I would argue that they are all child abusers and should all lose their license for lazy, unethical, ignorant, incompetent malpractice because they just don't care. That would be somebody going to have to explain to me why child abusing therapists should not lose their license. And if the individual child therapist has misdiagnosed the pathology, then they are a participating child abuser because of their negligent misdiagnosis. So, with that, that's my talk on treatment plans. We need a treatment plan for all these families. It should be written so the court can look at it. It should have goals, interventions, timeframes. It should be based on an accurate diagnosis. The only reason for failed treatment is there's only two possibilities. There is either misdiagnosis and we're treating cancer with insulin, or the diagnosis is accurate, but the treatment for that diagnosis is incompetently delivered. Because if there's an accurate diagnosis and competent treatment for that diagnosis, things are going to get fixed. So when we have, I'd like to see movement on my treatment plan within 6 weeks. And if not 6 weeks, I'm going to start to pay attention. What's happening here? Why aren't we getting movement? And certainly by 12 weeks, 3 months, I should see significant progress on my treatment plan. And for attachment pathology, we should have it resolved within 3 to 6 months. And so if we're not getting a solution based on the outcome measures, we're not getting normal range child in about 6 weeks to 3 months, then either we're incompetent in our treatment or we've misdiagnosed the pathology. And so that's what we go back and look at. If we're not getting treatment progress, if you go to your physician for some medical problem, they put you on some medications and your symptoms still are there, that medication's not working. And so maybe we have a misdiagnosis and we should take a look at the situation again. So with that, I'm going to end off this Sunday coffee and head off to my Sunday. Good luck to everybody out there. I'm available to consult with all these mental health people if they're ever motivated to actually start, doing quality professional services. But with that, I'm out of here and we'll talk to you next Sunday.